So you're going to get really a high level educational experience this morning then. So you've probably looked at these already, right?
Yes.
I'm going to focus on this bottom one.
Yeah, so this is a shave of, looks like a hyperkeratotic lesion with sort of a good amount of, I think, crust on there. Probably was some sort of like crusty papule.
Yeah, I agree. It's got to have some surface change to it. Then you've got this piece over here, which kind of looks a little bit different.
Yeah, I would say that infiltrate looks, this one less so, but it almost looks like a interface dermatitis of some sort. Although it could be a neoplasm too, just based on the architecture of the lesion. Like it's kind of well circumscribed and it has like a good start and end to it.
Yeah, good. That's good. It almost looks, if you just look at low power, say, wow, the epidermis is kind of thickened. It kind of looks like a seborrheic keratosis a little bit. And then you look at this other side over here, you say, wow, it kind of looks a bit like a seb K. But then you start looking in areas like over here. Did you notice these cells here?
Yeah. I don't know if those are melanocytes, or that's what I think they are. I mean, they look like
they are. They are. It's exactly what they are. They're nest of melanocytes. So, and sometimes we'll see nevi, and they have like epidermal hyperplasia, kind of almost look like a seborrheic keratosis-like morphology. That I don't know exactly why that happens. It's probably somehow inducing the epidermis to be acanthotic like this, and it's really not all that uncommon, surprisingly. But notice all this dense inflammation that you see here. And in fact, it's so dense, it's almost obscuring. Like there's a nest of melanocytes there, and over here too. It's almost obscuring it. Sometimes it can be really difficult to see. But this is any idea what the diagnosis might be?
Like what I was thinking was lichenoid regression of melanoma, or like just inflamed nevus, or even like a halo nevus.
Yeah, good. And this is actually what you see in a halo nevus when you get a classic one. They get this really super dense infiltrate. This is a sort of a red herring. They don't usually get this acanthotic epidermis that kind of looks like a seborrheic keratosis. That's sort of an unusual finding. But when you see halo nevi, they get such a dense inflammatory infiltrate. It's usually, like you noticed, relatively well localized like this. It almost has kind of a lichenoid type morphology. It usually has a relatively flat base of the inflammation. And again, I think that's because it's just sort of targeting where the nevus cells are located. And then you don't want to overcall it melanoma, obviously. So you want to look and see if you can identify the morphology of the nest. You can see they're pretty small and not very atypical, no mitotic figures or anything like that in there. So this is what you see in a halo nevus. Now, what's interesting is that you can also sometimes see clinical halo nevi. We actually just saw one about 15 minutes ago that have no inflammation or very little inflammation, but they have a clinical halo around them. And it was sent in to us as halo nevus, and we said, well, it sort of didn't look like a halo nevus histologically. It just looked like a regular nevus, just a little bit of inflammation. And then we actually were able to pull up the clinical picture, and it had a nice halo around it. So there's often a clinical discord, if you will, in some of these lesions. Sometimes they can have a lot of inflammation and no halo. Sometimes they can have almost no inflammation and have a pretty significant halo. So I don't know why that is, but it sort of breaks the rule. And if you get a completely regressed halo nevus, it pretty much looks like vitiligo. If you actually go in and let's say all the nevus cells are gone and there's just a little bit of residual inflammation, you stain for melanin and melanocytes in the epidermis, they will be completely gone. And so if that's ever on a board question, you'll say, yeah, the melanocytes in the epidermis and a completely regressed halo nevus are absent. There's nothing left there. Looks like somebody else.
Distinguishing this between like regression of melanoma is still about like cytology of the nest and configuration of the nest.
In part, Basically, if you, like you said, when you looked at a low magnification, you said, well, overall, this thing looks pretty small and symmetrical, well circumscribed. If you get regression melanoma, it's almost always a broad zone, and you get what's called melanosis. You don't usually actually see quite the dense inflammation like you see here, interestingly enough. By the time you get a regressed melanoma, it's usually just sort of almost a patchy infiltrative lymphocytes with melanophages and kind of a loose, almost fibromucinous stroma that extends over a pretty broad front. And you may have a few residual melanocytes in the epidermis. You may not have very many residual melanocytes in the epidermis, but overall it has the architecture of something that looks, broad and not well circumscribed. So halo nevi are usually, they're like nevi, so they're going to be small and well circumscribed and symmetrical and all those kind of things. They just have a dense inflammatory infiltrate in them. The other thing that we do run into difficulty with sometimes is distinguishing between a completely regressed benign lichenoid keratosis and a regressed melanoma. That can be more challenging. And there you have to look off to the side and see if you see a change that looks more like a little, seborrheic keratosis with some, a little macular solar linigo with some solar elastosis in the dermis. That can be a clue that you're dealing to a regressed BLK, but those can look pretty similar to regressed melanoma. And sometimes we recommend sizing those and following the patient if there's a question to that. Usually there's not much of a question of it. So, okay, let's move on to the next one. We've got a couple more folks who joined in, so welcome. Everybody probably stayed up watching the Mavs win their first game last night, so that was sort of a anticlimactic thing. I have a feeling they're probably not going to last too much longer, but at least they won one game, so they can say they won a game. Okay, who wants to give this one a go?
I can try this one. Can you hear me?
Yeah, we can hear you.
Okay. And I wasn't certain on this one, so please tell me as I go the wrong direction.
Okay.
Get page. So I think that this is acral surface.
Good.
My thought was is this a nail, like the nail plate?
It's not nail, and you can see there's still some sweat glands down here. So it's actually, you're right, it's acral. It's probably like near palm or sole, something like that.
Okay. So then there's I don't know, erosion with some overlying, I guess this is serous crust.
Yeah, I think there's probably some crust up here, and it's probably almost kind of like an eschar. If we'll go to higher magnification in a second, you're going to see that it's not comprised purely of just dried serum and red cells. It's actually got some epithelial cells in there too. So obviously, you think it's inflammatory, right?
Right.
Okay.
Epithelial, along with the epidermis, there's a little bit of acanthosis with elongation of the reedy ridges, some perivascular infiltrate, and a little bit of a band-like infiltrate in some areas.
Yeah, it's pretty dense infiltrate. What kind of cells do you think mostly here?
Mostly lymphocytes.
Good. Now, what's going on in the epidermis?
There did seem to be some either spongiosis or I don't know if that would be considered marginization, if that's a viral. I don't know if that's viral side. I don't think it's viral.
It is viral cytopathic effect here. See those little things right there? Absolutely. And so there's three kinds of ways you can get an intraepidermal blister, right? Three main ways. What are the three main ways that we have to think about?
You have the ballooning degeneration.
Good. Ballooning.
Spongiosis.
And what's the last one?
And then I think an actual split.
Yeah, acantholysis. Acantholysis like pemphigus and focal acanthodisc keratosis, variate, that sort of thing. So of those three, which one are we looking at here?
I think this is ballooning.
Good. This is ballooning degeneration. And when you see ballooning degeneration, again, we like things that have short differentials with them. What are some of the things that can cause ballooning degeneration?
Viral.
Viral is number one. Yeah. That's number one. Sometimes you can get things like, well, like the deficiency diseases. You can get ballooning degeneration in those. Certain irritant reactions can cause ballooning degenerations. Photodermatitis, like juvenile springtime eruption, hydroestivale, those can give you ballooning degeneration. Not too many. So there's not too many. When we see it, we really think about virus. And you said viral intracellular and intracytoplasmic and probably even intranuclear inclusions here that we're looking at. So you're right. This is a viral illness. And let's look up here. All this stuff up here that you thought was just crusty. Look at all that. These are all dead cells here. So this is an eschar. An eschar is a combination of dead epithelium plus serous crust or hemorrhagic crust and that sort of thing. It almost forms like a leathery type of covering. Like if you do a D&C of a basal cell and you burn all that stuff, you're kind of creating an eschar at the top of that in a way. So what is the diagnosis here?
When I think like acral viral, you could be like, I think ORF or like a herpetic whip.
Are you okay? Herpetic Whitlow is now what's not so great about herpes here?
It doesn't really make that eschar, really, unless you're like, I don't know.
It usually doesn't unless you're really really a severely immunocompromised patient get like a syncytium of multinucleated giant cells, and they can do that sometimes. But those cells also, these are, number one, they're not multinucleated, right? These are just ballooned, large, swollen cells, and they're not acantholytic. So herpes, the cells fall apart. That's why you can do a zinc preparation, for example. So this is a different kind of viral process. So what type, you said ORF, what's that type of virus known as? What's that family fall into? This is a very timely biopsy for you guys to be looking at right now.
Oh, is it? Oh my gosh, I can't remember. Is it
Yeah, it's the pox virus family, parapox virus family. And so what's our big virus that we're all worried about right now in the United States and the world? Monkeypox. You know, and if you see a biopsy of monkeypox, it's going to look like this. It's going to look very much like this. It's not going to look like herpes. It's going to have this ballooning degeneration of these large cells with this basically this eschar. It's going to look pretty much like ORF or Milker's nodule or Yabapox or Tamapox, any of those kind of pox viruses. That they all pretty much look the same, except for molluscum. That doesn't usually give you the pallor of the cells. It just gives you the inclusions here like this. So these look kind of like molluscum bodies. They're in the same family as molluscum bodies. And if you actually took an electron microscope and zoomed in on these, it would look like little bread loaves inside there. So this was ORF in this case. I don't really think you can reliably tell the difference in ORF and Milker's nodule and any of these things. To me, lump them all together. They all basically look the same. The only one that looks a little bit different is cytomegalovirus. If you get like a ballooning degeneration of those cells, it's usually just a few individuals. They're not usually involving the epidermis. Those cells usually are involving endothelial cells and fibroblasts in the dermis. Occasionally they can get into the epidermis. Hand, foot, and mouth disease, Coxsackie virus, that also can give you ballooning degeneration. Usually though, there you don't get this massive amount with this prominent acanthosis. It's just a small focal area. It would kind of look maybe just like this area if it were C and V. So that's another virus that can give you ballooning degeneration. So that's good that you knew that. They could very well ask you this on the board examination. And because of this monkeypox being kind of a hot topic that we all need to know about, they very well might put this on there and ask you some questions about it. So good. You got that one. That's great. Okay, who wants to give this one a go? We got a few people on.
I can try this one.
Yeah, I can try
Okay.
again. I can go, Audrey.
Okay.
So this is a neoplasm of some sort. And I think the epi, it almost looks like this like soft little papule filled with something.
Yeah, good. It's a papule. And what do we call this phenomenon right here?
It's almost like a pseudocapsule to
Yeah,
me.
it's sort of like a collarette of epithelium that's just kind of surrounding the entire thing.
Yeah.
That's a sign almost always of benign when you see that. It's
Right.
usually means that it's something that is slowly kind of, well, it doesn't have to be slowly, but the epidermis has kind of formed a little, like you said, like a little, not really a capsule, but it's kind of walling it off from the rest of the world, if you will. Okay, so you think it's a neoplasm. So it probably
Yeah.
would be benign. It's obviously very symmetrical and well circumscribed, the epithelium surrounding it. And what kind of differentiation do you think is exhibiting?
It almost looks like there's, I don't know if that's mucin or if it's like this reticular sort of substance.
Magnification. A lot of this is sort of,
Just like sweat even.
well, it's probably, some of this is probably some serum and maybe
Okay.
some fibromucinous kind of stroma here. And
Yeah.
then what about all these other areas up here? What are these cells here?
I mean, there's neutrophils in there.
There are the neutrophils in it. Good.
And I don't know, are those little vessels
The
or
blood
like,
vessels. Yes, there are
okay.
lots of blood vessels. And over here, you can see that they're kind of almost forming a little lobule, if you will.
Yeah.
And
Yeah.
we sometimes refer to that as lobular capillary proliferation.
Well, I mean, maybe this is a pyogenic granuloma then.
Okay, it could be a pyogenic
Um,
granuloma. That would probably be number one on the list. Is there anything a little bit unusual about it for pyogenic granuloma, though?
I don't usually think of the neutrophil part.
Good. You do not usually see this many neutrophils in a pyogenic granuloma. Usually you'll see more of an edematous stroma with lymphocytes most of the time. And usually pyogenic granulomas, they're kind of eroded and they're not really
Right.
covered by epithelium. So it's a little bit funny for a typical pyogenic granuloma. And
This
then
doesn't
also,
really, go ahead, sorry.
no, I was just going to notice that this kind of looks sort of fuzzy and kind of pinkish and a little bit amorphous, some of these areas here too.
Hmm.
That's kind of a clue to this diagnosis also.
Okay. Well, I was gonna say it doesn't really like, you know, go with what I was thinking, but as far as like when I see capillary proliferation, I would think the neutrophilic infiltrate would be much more dense for something like bacillary angiomatosis. But I think I was thinking about that. It would be probably more hemorrhagic than this, but I'm not sure what the stringy pink that you're getting at is.
That's the actual amorphous material that if you actually stain this, it stains very strongly positive with a silver stain. So if you do a Steiner stain or Worth and Starry stain, this stuff right here lights up. That's actually not the capillary. That's this pink amorphous material that's actually the organisms that cause this disease.
Oh,
So
so it
this
is
is,
bacillary
this is
angiomatosis?
bacillary angiomatosis. And they look very much like a pyogenic granuloma, but there's a little bit of distinction between it. The neutrophils, and they usually don't give you like a suppurative neutrophilic infiltrate. It's usually sort of like this, maybe a little bit denser, but not a lot. It depends on there's a spectrum. Sometimes you can see some that really have more neutrophils than others, but this sort of, if you can kind of appreciate that sort of fuzzy amorphous kind of characteristic, that pinkish amorphous material, you don't usually see that in a pyogenic granuloma, and that's helpful. So if you see that, a little bit more cellular, a little bit more epithelioid. In fact, when we first reported this before you were born, probably, we called it epithelioid angiomatosis because these cells are so epithelioid, they really look more like an epithelioid hemangioma. If you've ever seen a biopsy of like an epithelioid hemangioendothelioma or an epithelioid benign hemangioma, they really look very epithelioid like this. So our original diagnosis, before we knew it was caused by a bacterium, was that's the first case reported in Lancet back in the 80s. But basically, it was determined that this was caused by a bacterium. And there's one other disease that can look identical to this histologically. You may or may not know it. So it's Bartonellosis or Verruca peruana, which is actually the same kind of, or it's caused by Bartonella. We now know this is caused by Bartonella henselae, and that's an organism that was named after Diane Hensel, who was a laboratory worker at the AFIP who first, I think she actually isolated the organism and grew it, although we had the first example of electron microscopy published on this. But basically, it's the same thing that causes Carrion's disease that killed millions of workers when they were building the Panama Canal and doing things down in South America back when Roosevelt was president. And it's the same basic entity, only one's carried by flies and whatnot down in the middle of South America and Central America. This is obviously associated with fleas and cats in the United States. And it's the same organism that causes cat scratch disease, the lymphadenitis disorders. It's kind of interesting that the same organism can cause this proliferation of these vessels, and it can also cause a suppurative lymphadenitis. That doesn't respond very well to therapy. This responds beautifully to things like erythromycin and tetracycline. So it's sort of a mystery as to why you've got one disease with two different complete manifestations in different settings, one in children usually, and then one in patients with HIV infection. Not always seen in HIV. We had several of these case reports in non-HIV infected people. But anyway, it's a good example of it. It's beautiful. I don't remember. I think we saw this maybe about a year ago. So we're still seeing a few cases. Usually they're in patients that are HIV infected, but they don't have any, they're not on any medications, and they have low CD4 counts and just kind of get it coincidentally. All right. Who wants to give this one a go?
I could try this one. So seems like a lot of pretty extensive like epidermal hyperplasia, potentially like pseudoepithelial hyperplasia here.
Good. Excellent.
And then let's see.
You think it's like an inflammatory process?
It could be. I mean, I think I'm seeing some islands of like potentially neutrophil, like lymphocytes and neutrophils. So
yeah, right. Neutrophils, lymphocytes, and then if we look around, I'm sure we'll find some histiocytes in here also. Like over here, there's some granulomatous inflammation. So what's the general category that we think of here when we see this pattern?
yeah, so like PEH with, I think there's a focal collection of pus as well. So I would think I'd be like more inclined to look for an infectious etiology.
Excellent. Suppurative granulomatous dermatitis with pseudoepitheliomatous hyperplasia, infectious until proven otherwise. So absolutely. So you're gonna instantly start hunting for some organisms that cause this, right?
Exactly. Yeah.
So this is going to be on your exam. You will definitely have something like this on there. They're going to throw this up there and they're going to say, okay, let's see if they can find the bug. So where do we want to look?
I would look in the collection of where I guess a neutrophil collection.
Good. That's the easiest and best place to look quickly. So let's look in here and see if we see anything, because usually if there's neutrophils, that's acute inflammation. And so they says, hey, there's an organism that shouldn't be here. And they send in the polys first to try to kind of kill it. And they may not be able to do it, but there usually are some organisms left there. You don't see any there. Another place to look is in to see if you can find some multinucleated histiocytes. And sometimes you'll see the organisms kind of inside the cytoplasm of the histiocyte. So you look there also. And so far we don't see any. We're going to keep looking. And, so if it's a hard one to see on H&E, they probably are going to give you a special stain. And this one, so far I don't see. Another place to look is if you go up the top, bugs like to get transepidermally eliminated. So look up in this area too. If you see evidence of transepidermal elimination, there's a couple of little holes here. That's kind of a clue that might be an organism. And then let's look in the crust. So look up here. A lot of times you'll see some organisms, lurking up here. That probably is one there. That might be one there. And what we're looking for in this case, I think that is probably one there, are broad-based budding yeasts. So let's say that we found broad-based budding yeasts in this pseudoepitheliomatous hyperplasia here with suppuration and granulomatous inflammation. What would be the diagnosis?
Blastomycosis.
Good, blasto. So this is blasto. Again, I'm not going to sit here for the next 5 minutes and see if I can find a good organism for you, but go back and look at the slide and see if you can find some. It's good to see if you can pick it up on H&E. Just good for practice. There's definitely something in here because we made the diagnosis, but on a board examination, if you can't see a lot of them, they're probably going to give you a stain that sort of highlights it, like a silver stain, a GMS stain, or a PAS stain. And probably the one that's easiest to find is chromoblastomycosis with H&E, because that obviously the organisms themselves have melanin and they're already colored for you, so you don't really have to stain them. Blasto's a little harder to see. I'm not really seeing any here that are just standing out. So I think if you go back and search the slide, you'll find some organisms in here. But the key to this is recognizing the pattern and then realizing you need to start going on a hunt to see where the organisms are causing it. So this is blasto. They're in here somewhere. Okay, so you'll get that on the exam. So be prepared. Don't say I didn't warn you. Oh, actually, this might be the PAS of it. Yeah, this is the PAS stain, I think of it. So maybe we can see some here. Well, I'm not going to spend a lot of your time on this. We don't have a ton of time. So we'll just move on. But go back and look at the PAS stain and see if you can find them there. Okay. This one may be a little bit of a no, it's there. Okay, good. Okay, who wants to give this one a go?
I can do it. I will warn you, I did this at like midnight last night, and I'm now not remembering anything that I thought. So
no problem.
So I'm seeing a, I guess this is probably either puntric excisional biopsy. My guess is from the face, just because of the sebaceous and hair glands.
Yeah, there's sebaceous lobules here. It's near the facial area. You're right. There's a little bit of, what's this down here, however?
Yeah, like muscles. So it might be like the eyelid.
Yeah,
or it could be like the scrotum.
It could be, or another place like the lip.
Yeah.
Yeah, so it's like mucosal, near mucous membrane. These are skeletal muscles here. So this is an area where they are moving, their skin. This isn't just smooth muscle bundle. So this is an area where there's some actual, the area is moving. So do you think it's inflammatory or neoplastic?
Probably, well, I'm not really seeing a ton of inflammation. Well, except for like that. Is that a granuloma right there?
Yeah, granulomatous inflammation here. Okay, good. And what's the pattern of the granulomatous inflammation?
I'd say probably sarcoidal. It's naked.
Good. Yes, sarcoidal granulomatous inflammation. Excellent. So once again, differential diagnosis goes down significantly, right, when we have that pattern. So let's say we're near mucous membrane. Maybe we're on the mouth. We've got sarcoidal granulomatous inflammation here. So what's our differential diagnosis?
Is there like the cheilitis granulomatosis?
Yes, good. That's one of them. Now, what all falls in that spectrum of cheilitis granulomatosis?
Oh my gosh, we're getting down deep. Let's see.
There's not too many things, though. There's not a lot. There's really not. It's just a couple.
Well, I just don't know them.
You do know them. You just need somebody to draw it out of you. That's what a good teacher does, draws it out of you. So.
I mean, like, obviously sarcoid can do it too. And then I think Crohn's and sarcoid. Crohn's and sarcoid can't look different.
Yeah, Crohn's and sarcoid, those would be two things that you would think about. What if the person had the funny tongue problem and it was furrowed
That's
tongue?
the
Maculosis.
the Meckerson.
Melkerson Rosenthal.
Yeah.
Rosenthal. Okay, those are really the ones you have to think about. Sarcoid usually is going to give you a denser, more diffuse granulomatous inflammation rather than just these sort of scattered little granulomas. Crohn's could definitely look like this. Crohn's often has more sort of other inflammation. It's in my experience, it's usually not just purely these little fine little sarcoidal granulomas like this, but it could be. So this is basically the diagnosis here is orofacial granulomatosis, or basically cheilitis granulomatosis, like you said before, which is sort of in the same family as Melkerson Rosenthal. The only other one I would put in the differential would be granulomatous rosacea, or perioral dermatitis, which can give you granulomatous inflammation. Again, that's not going to give you these nice, fine little isolated sarcoidal granulomas like this. So if you had somebody that had this, you want to make sure they didn't have Crohn's disease. You probably want to make 100% sure they didn't have sarcoid. They probably wouldn't, but you certainly would want to make sure they didn't have underlying Crohn's that was missed. So this would be fair game to give you on a board exam also. Recognize that it's sarcoidal, know the differential diagnosis. The only other thing you'd throw in there is maybe a foreign body reaction, a sarcoidal granulomatous foreign body reaction, say to maybe a silica, maybe the person got injured in a car wreck or something, and so you polarize this to make sure there wasn't anything in there. Less likely would be an infectious process, but it could theoretically do this. If you had, say, tuberculoid Hansen's disease, that would be in the differential. But the good news is that it's really a relatively small differential diagnosis. So when you see this pattern on the mucous membrane, you should think of really Crohn's and cheilitis granulomatosis sort of first, and then think about those other things second. So good. All right. A lot of good inflammatory stuff this morning for you guys.
All right, this is a punch with, it's probably from, I think, trunk or an extremity or something.
Yeah, it's sort of a bland looking area of the body. It doesn't really have a thick cornified layer, and then a lot of hair follicles or sebaceous lobules. So yeah, this is the most common place we like to take biopsies from an inflammatory skin disease. And we avoid the face, we avoid the palms and soles if we can. Right. So yeah. And so what's the general pattern we're looking at here?
Looks largely like a superficial dermal infiltrate, and almost like interface, like it could be, it's almost lichenoid in some areas.
Yeah, it's pretty dense locally over here.
Maybe a little perivascular too.
Perivascular, and then kind of involving the papillary dermis up here. It's not really getting down to the reticular as much, is it?
Yeah, it's mostly superficial.
And what about this?
Oh, right there.
Yeah, what about
yeah, there's intraepidermal acantholysis, I guess.
Look at
or
it.
At least split.
There's a subepidermal blister.
Yeah.
So remember, that's one of the 9 inflammatory patterns, right?
Yeah.
And so subepidermal vesicular dermatitis. Good. Now, when you get that pattern, so recognize that it's subepidermal blister, especially if you see something like this. So what's your approach then?
Well, then I like to see if it's inflammatory or not.
Okay. Is it inflammatory?
I think it is, yeah.
Yeah, so that's going to rule out non-inflammatory subepidermal blisters like epidermolysis bullosa and those kind of things, right? The mechanobullous diseases. So we're going to forget about that category.
Mm-hmm. And now I want to see what the inflammatory cells are.
Good. What are they here mostly?
Looks like EOs. And
there are some EOs.
Maybe some neutrophils too.
Yeah, there's quite a few neutrophils.
Yeah.
There's like a ton. But there are EOs too. There are EOs too. That's important.
I mean, I think you could think about like neutrophil rich BP.
You could think about that. Is that the first thing you're going to think about?
No, but I think the other things.
What's the first thing you think about when you think about subepidermal blister with neutrophils? The first thing we want you to think about.
Yeah, that's a good question. Actually don't know. Someone wants to help me.
Well, dermatitis pediformis, DH.
Oh, that's right. Okay.
So just
cool.
remember that one. So that's number one. That's the first one, the most common one that we see.
For
The
some
second-
reason, I usually think of those as like microvesicles, and these look like large to me, or at least larger. But
They
that makes
can be
sense.
pretty big sometimes, you know, they can actually, you can get fairly large blisters with DH. And if you look here to the edge over here, you see the nice little neutrophils at the tips of these dermal papillae
Yes.
right there.
Yes.
So this is an early lesion, and then sometimes they actually go ahead and form blisters. So, you know, look at the size of this blister. It's probably a 4 millimeter punch. That's like a 2 millimeter blister. That's
Okay, that
not
makes
really
sense.
huge,
It's
you
pretty
know, when you
small.
think about it. So, you know, they might have biopsied the edge of the blister, but it still can give you a blister of this size. So,
Okay.
so if you see neutrophils mostly, think DH first. What are you gonna think about second?
I mean, I guess BP or lupus.
I'd probably go with linear IgA second,
Okay.
because that can, you know, again, drugs and things like that can give it to you. Then you can see neutrophil-rich pemphigoid sometimes. That's relatively rare. We don't see that all that common. Bullous lupus, don't usually get EOs in that when you do see it. So that's less common too. Usually get lupus, those patients are usually sick as a dog, and they usually also have kind of a lymphocytic infiltrating the dermis deep and some mucin. So it's kind of like a combination usually when you see that. But it could look like this, but usually wouldn't have the EOs. The good thing to point out, you notice the EOs, you do get EOs in DH also. So just remember that. It's not like, you know, you don't get eosinophils in that too. You can get eosinophils, especially kind of later lesions. So you see the early area over here, there aren't too many EOs. But later on, after the blister forms, you get plenty of eosinophils in here too. So that doesn't mean it's not DH. And the other thing is, you'll notice you got a couple of acantholytic cells. Anytime you get acantholysis, I mean, neutrophils, lots of polys, you can get secondary acantholysis. So this isn't really an acantholytic process. It's kind of secondary. Probably the real classic pathology is this kind of the other one over here, where you've got the subepidermal blister with the neutrophils primarily. So this is dermatitis pediformis. And just, again, remember the difference of diagnosis and how you walk through and work through a case of subepidermal blistering. Ask yourself what is it inflammatory or not, what you did, which is good. Then ask what kind of inflammation is in the blister, is beneath the base of the blister in the blister space. If it's neutrophils, it's some of those diseases. If it's eosinophils and lymphocytes, mostly it's usually bullous pemphigoid, maybe a weird, bullous drug eruption. So just work through it that way, and you'll be able to come up with a differential. So they'll show you this. You're going to get this on the board also. So you'll definitely get a question or two about DH, or a question or two about subepidermal blisters, either in both in the basic science as well as on the pathology. So last one, we have about 1 minute. Anybody want to do this one?
Yeah, it's like a verrucous sort of appearing like papule.
Good.
Pretty like extensive acanthosis, hyperkeratosis. Let's see. And there's some hemorrhage in there as well.
Does it look like a classic wart?
No, not quite.
Looks a little bit different, doesn't it? Doesn't really have any viral cytopathic effect. It's got a lot of neutrophils up here. It looks like it's super inflamed. It probably looked red and weeping and crusting. And then let's take a look here in this area. What do you see here?
Those, let's see, I'm trying to zoom in. Like more foamy sort of cells.
Yes, foamy histiocytes with verrucous epithelial hyperplasia, with neutrophils, serous crust at the surface. There's some serum up here. It's crusted, a lot of dilated blood vessels, probably from near mucous membrane location. Anybody know what the diagnosis is?
The Verruciform xanthoma.
Good. It's Verruciform xanthoma. We don't know what these things are. I mean, some people think that they're not really xanthomas, that maybe it's some kind of just reactive process due to chronic trauma, and they get epidermal hyperplasia, and then the histiocytes kind of come in there secondarily. So it's probably not really a xanthoma, but that's what it's known as. That's the name of it. And this is what it looks like. It's a good name because it looks like a wart, but it's not really a wart. And it's got all the xanthomatized foamy histiocyte-like cells in here too. You can actually, interestingly, see those same kind of foamy histiocytes in Fox Fordyce disease. So those cells are probably reactive and probably related to the inflammation and all the irritation that's going on here associated with the lesion. Okay, any questions about anything we covered today?
Thank you.
All right, well, thank you guys. Good job.
Thank you.
Thanks.
See you next time.